demyelinating disorders of CNS. Part 3, ADEM. Okay, in this, what is ADEM? ADEM is acute disseminated encephalomyelitis. Acute disseminated encephalomyelitis disorder. Okay, acute disseminated encephalomyelitis disorder. Okay, from the name only we can say that it is acute, and this is a single attack is that. So it is monophasic illness, and it is diffuse disorder rather than focal. Acute monophasic illness, diffuse disorder rather than focal, and it is triggered by viral infections. Myelitis, viral infections. Acute disseminated means diffuse. Myelitis means related to viral infections, and they are from M only we can say monophasic. It is mainly seen more common in children than adults. Okay, now it is the clinical presentation. In case of the clinical presentation, demyelination, it is always bilateral and affects the in case of demyelination, in acute disseminated encephalomyelitis, the demyelination is bilateral, and in case of cortex, deep grey matter is involved. Okay, demyelination is always bilateral in case of ADEM. Deep grey matter is involved. Cortex, subcortex area, cerebellum, spinal cord, meaning whole of the thing along with basal ganglia. Demyelination in acute disseminated encephalomyelitis represents these all from BCS, okay, BCSB by CCS, okay. All these structures are diffusely affected in this case, and definitely no dorsal fingers are there. Okay, no dorsal fingers are there, and bilateral optic neuritis is seen. In this case, bilateral optic neuritis is seen. In case of clinical presentation, we have seen the involved or affected part. After this, all these structures, they are diffusely affected and no dorsal fingers are seen, and bilateral optic neuritis is seen. ADEM is triggered by. Now, ADEM is triggered by vaccinations and viral infections. These clinical stages, they are related to vaccination and viral infections. Most commonly, exanthematous, viral, varicella, measles, chicken pox, etc. Okay, all these structures, they are diffusely affected in demyelination. In clinical phases, in no dorsal fingers and bilateral optic neuritis is seen. Earlier, measles was the most common infection, but now varicella is considered the most common viral infection causing ADEM. Now, during recovery from xanthan, this is measles or varicella zoster, chickenpox, the patient appears with the reappearance of fever accompanied with headache, meningism, and lethargy, and it may rapidly progress to coma and may lead to development of seizures. Okay, now what do we write? Started in the clinical presentation of ADEM: cortex, subcortex, cortex, cerebellum, first of all basal ganglia, spinal cord, subcortex, cerebellum, and cortex deep grey matter, they are involved, and all these structures, they are diffusely affected. And no dorsal fingers are seen. Bilateral optic neuritis is seen in this case. ADEM is triggered by vaccination and viral infections like xanthematous, viral fever, like measles, chickenpox. Early measles was the most common infection, but now varicella is considered the most common viral infection. Now, during recovery from xanthan, the patient appears with the reappearance of fever, okay, accompanied with headache, meningism, and lethargy. Okay, during this recovery, the patient may appear with any kind of reappearance of the fever, with the symptoms of headache, meningism, and lethargy. And it may rapidly progress to coma also. Rapidly progress to has seizures. Demyelinating and lethargy. Now what is the diagnosis of ADEM? How can you do that? We can do it by two rules, MRI and CSF. In MRI we have multiple contrast enhancing demyelinating punctate to large tumor-like lesions which are bilaterally symmetrical, affecting both grey and white matter. Now in MRI, okay, so in MRI, in multiple contrast enhancing demyelinating punctate to large tumor-like. There is demyelinating punctate to large tumor-like lesions which are bilaterally symmetrical, affecting both grey and white matter. Okay. Now what is the meaning of punctate to large tumor-like lesions? It means that the lesions can vary in size from tiny dots, small dots, punctate. Okay, tiny dots of demyelinated to large compound areas. Okay, that may make a big brain tumor imaging. And they are usually bilaterally symmetrical, affecting both grey and white matter. Now after CSF, now after MRI, the main key point is demyelinating punctate to large tumor. In CSF, it is very similar to viral meningitis. That is, increased cell count is there. In viral meningitis, lymphocyte predominance is there, and minimal increase in proteins is there, and occasionally oligoclonal bands may be seen. Now in CSF, since it is related to viral meningitis, there is increased cell count, and lymphocytes they are dominant in viral meningitis, and minimal increase in proteins is there. So there will be some increase in proteins, there will be but it is minimal, and occasionally oligoclonal bands may be seen. This is the diagnosis of ADEM. After that, management. In management, we have what is ADEM? ADEM is autoimmune. It is an autoimmune disorder. So it is an autoimmune disorder with anti-myelin basic protein antibodies and anti-MOG antibodies. In this case, what is ADEM? It is an autoimmune disorder with anti-myelin basic protein antibodies and anti-MOG antibodies. Drug of choice is, since it is autoimmune, high dose of steroids. And second line treatment is plasma exchange of IV immunoglobulins. So, summing up this whole ADEM, it is acute, diffuse, disorder rather than focal, and for more common in children than adults, and monophasic illness, and which is triggered by viral infection. Clinical presentation is demyelination is always bilateral reflection, basal ganglia, cortex, cerebellum, spinal cord, and subcortex. Now in this case, usually the main causes are triggered by vaccine viral infections, most commonly xanthomatosis viral infections such as measles, smallpox. Early measles was now visualized, and after the recovery, clinical recovery from xantha, the person may present with appearance of disease accompanied by headache, meningism, lethargy, coma, and messages now recurring. And all these structures are diffusely affected. Okay, no Rosen syndrome, optic and bilateral active. And besides headache, meningism, lethargy, what is the diagnosis? Demyelination of punctate to large tumor-like lesions which are bilaterally symmetrical, affecting both grey and white matter. And in case of viral meningitis, there is increased cell count, lymphocytes increase cell count, the lymphocytes predominate, minimal increase in proteins and oligoclonal bands are there. After that, management of ADEM is due to autoimmune, since it is an autoimmune disorder with anti-myelin proteins, and also anti-MOG antibodies and topical steroids, second line treatment for medicine that